Okay, good. Right. Okay, so thanks very much for the invitation, Wenki, and the Institute. And just to say that this work is partly supported by the European Union's 7th Framework Programme, the Ideal Programme for Research, Technology and Development. And that's a particular program about developing techniques for studying rare diseases. So this is a previous Prime Minister of the United Kingdom, and this is David Cameron, and here he talks about how we're going to unlock the power of DNA. Everybody's very excited about unlocking the power of DNA, although recently I saw a little survey on the internet saying, which do you think is more predictive of a patient's health? Their complete genetic readout or their credit card details? Plausibly the answer is that if you know their credit rating, you know a lot more about their health than if you have their DNA rating, usually, with some exceptions. So it's going to deliver better care for patients. Here we have Sir Richard Sykes, 1997. At the time, he was the chairman of Glaxo Wellcome. He was about to become the provost of Imperial College. He was attempting to oversee the merger of Imperial College and University College London. Thank goodness he didn't succeed. I'm a University College London man myself one time. And he eventually oversaw the merger of Glaxo Wellcome SmithKline Beecham. Somebody, and he's a fellow of the Royal Society, someone who should know something about this. And here he promises us that it will soon be possible, and this is 20 years ago, soon be possible to have clinical trials which are much, much smaller and much, much cheaper, and everything is going to be more precise. And any of you know anything about drug development know exactly the opposite has happened. In fact, what's happened is trials have got much more expensive because we're collecting lots and lots of genetic information we've no idea what we're going to do with. So here we have an FDA report from 2013. And this is paving the way for personalized medicine. And here we have a nice little chart showing us a number of diseases and showing us the proportion of patients who don't respond. And then we also have some meaningless chart junk here. These, I think, are Irish dancers. They keep their hands down. These are Scottish dancers. They keep their hands up. Some sort of pictogram representing who responds. But, you know, they've sorted things, not alphabetically, but they've sorted them by importance. And they've also concentrated on what remains to be done. So in the words of Meatloaf, 2 out of 3 ain't bad. We can maybe forgive them this particular thing here. But the first question is, where do they get those figures? How do they know that this is true? How do they know the percentage of people that don't respond? And this is really weird. Here we're talking about cancer. What on earth is cancer as a disease? Here we're talking about something where your 5-year survival chances, if you have testicular cancer, are way, way up in the high 90s. And if you've got lung cancer, they might not be in double figures. So somehow this comes to be 75% response. So where did they get this from? Well, actually, they tell you where they got it from. So they got it from Spear, Heath, Chiozzi, and Huff, Trends in Molecular Medicine, May 2001. Now that should set alarm bells ringing, because here we've got an authoritative report based from 2013, but the claim for what doesn't work in medicine is what didn't work 12 years earlier. This is really strange. This is prehistory in terms of pharmacogenetics. And the other question is, where did these people get it from? Well, they actually said where they got it from. They got it here, the physician's desk reference. And quite frankly, I knew that this particular story would end in this sort of rubbish reference in the end anyway. There is no way that these people, by studying the physician's desk reference, could come up with figures like this that anybody could believe in, and certainly there's no way in which a rival set of people setting out to study the same piece of work would come up with the same numbers anyway, and if they did, the numbers would be meaningless. We simply don't know this. So what can we say? And the FDA is the premier drug regulatory agency in the world. They should know what they're doing, and they haven't got a clue here. Absolutely not a clue. These are what are called zombie statistics. They refuse to die. I'll give you another example later. You find these things quoted everywhere in the internet. They're completely meaningless. Not only is the FDA claim not right, it's not even wrong. You couldn't even know what on earth they meant by saying 75% don't respond in cancer. You couldn't find a statistic to refute it because the claim is meaningless in the first place anyway. And this is the way in which all of your tax dollars are being spent, basically, by an industry which justifies the search for personalized medicine on something which is so self-evident that no statistics can be found for it. And in the words of the British comedian Vic Reeves, 88.2% of all statistics are made up on the spot. Here we have another thing, Cochrane review, only 10% people with tension-type headache gets a benefit from paracetamol. And here we have supposedly the premier evidence-based medicine organization in the world, and they tell you something like this, and I'm going to prove to you that this is complete nonsense. This is basically, it is based on a statistic at least, but it's based on a complete nonsense interpretation of statistics, which happens all the time, and I'll give you some other examples. And here we have basically how this works. 59% had no headache after 2 hours when treated with paracetamol. Why after 2 hours? Well, because 2 hours is a number that somebody chose at some time. So basically the situation is that if you had a headache which disappeared in 2 hours and 5 minutes, you didn't respond. But if it disappeared within 1 hour and 55 minutes, you did respond. And you're a completely different sort of person if that's the case, and therefore we need personalized medicine. And so what happens is 59% had no headache after paracetamol, 49% had no headache after placebo. The difference is 10%. 1 over the risk difference is the number needed to treat, and a number needed to treat of 10 means that only 1 in 10 people benefit. That's what they think. This is another one. This made its significance. Here we have a really nice piece of work, and it shows the wonderful influence of a fantastic pharmaceutical company called Novartis. Their particular method for studying dose response, and we have in the back one of the originators of this particular method, is so popular it's even being used by Merck. And here we have Merck studying one particular thing, which is response in migraine. But what all these intelligent people don't know is that the definition of response is nonsense in the first place. So here we have fantastic intellect, statistical brilliance being devoted into dose finding using completely ludicrous measurements for the way in which response. Again, it's the standard recognized by the FDA. If your headache disappears within 2 hours, you respond this. And here, this particular person wrote a very nice paper describing this dose finding approach, said it tells us we can help about 35% of migraine patients. No, it doesn't. It doesn't tell you anything like that whatsoever, and no number needed to treat can tell you anything like that, as I will show you. So here's the comparison between the two. The Cochrane collaboration meta-analysis, placebo-controlled trials of paracetamol and tension headache, 23 studies, 6,000 patients in total, outcome measure, pain-free by 2 hours. The Bayesian significance article, this is an explanation of Novartis' MCP mod dose-finding approach used in a trial run by Merck, 7 doses plus placebo, 517 patients in total, outcome measure, pain-free by 2 hours. Again, this same thing, slightly different disease, tension, headache, migraine, same thing, pain-free by 2 hours, that's response. And that's how we're going to be able to classify people into sheep and goats, responders, non-responders. So, but in both cases, they were only studied once. That's all that happened. And a dichotomy was used. And by the way, I say the problem is that most physicians suffer from a compulsive disease called dichotomania. They have to simply divide any continuous scale they see into 2 regions, good and bad. It's just a thing with them. A causal conclusion was drawn that went beyond simply comparing proportions. Bayern in significance talked about the proportion of patients who would respond, and Cochrane talked about the proportion of patients to whom it would make a difference in terms of response. So I'm going to take you a simple model, very, very simple, embarrassingly simple. An intelligent audience like this would not even need to have it explained. But I'm going to explain it to you because I want you to explain it to your life science colleagues. I want you to stop accepting the stupid definitions of response that they give you. I want you to get off your mathematical pedestals, and I want you to actually get involved in the business of defining response for patients, because until you do that, there'll be no progress. So the dichotomy will classify patients as responders or non-responders, but I'm going to use a very simple time model, and in fact a form of proportional hazards model. And we're going to be tempted to conclude that some patients benefit and some don't, and this is a permanent feature of each patient. So this is the numerical recipe. I'm going to follow closely what Cochrane looked at. I'm going to generate 6,000 headaches treated with placebo. And I'm going to use a mean of about 3 hours, just under 3 hours, because that will give me exactly, using an exponential distribution, will give me exactly the proportion of responders under placebo that were seen in the Cochrane meta-analysis. Then what I'm going to do is I'm going to take every single headache, every headache that I generated, I'm going to multiply the duration by 3/4. That means each headache will have its duration reduced by approximately 1/4, and I'm going to say that's the result under placebo. I'm then going to take the 6,000 pairs, I'm going to say, well, you can't actually do that, Stephen. You can't do that. You can't rewind time. You cannot treat a patient twice under exactly the same conditions. You can have a crossover trial, but even that's not the same thing. You can't do that. You're going to have to take one of the two values. One of them is counterfactual, one of them is real. So having got these 6,000 pairs, I will randomly erase one member of each pair. But remember, I am the God of this universe. I know what happened. I created a particular scenario in which every single headache for every single patient was reduced by 1/4 of what there would have been. That's what I'm going to do. And now I'm going to show you what happens. So these are the two curves here, and you can see, well, you know, I fixed things in my favor. I chose the length of time response. We can see that this is the curve. This is the cumulative time till response under placebo, and it's faster under paracetamol. And of course, eventually, every headache goes. That's the idea. And if we look at 2 hours, oh yes, we get 49% under placebo, and we get 59% under paracetamol. We get exactly the figures we had before. But this curve here is just a rescaling in terms of time of the other curve. If I measured it in terms of units of mean time to headache, the two curves would be on top of each other. I've simply moved the point on one curve a fraction to the left to get the other one. That's all. I've just accelerated the time to response. There's no question of anything else going on here. And remember, this particular model says that any particular patient at any one time could have a headache which was anywhere between 0 and way beyond 5 hours. It's not a permanent feature of any patient. It's exactly the same for any patient, but that's the way the exponential is. It doesn't really predict things very well. And that's the simplest of the time models we use. So here's an example of some actual pairs that I've generated here. Here are just a few of the 6,000. Here we have some values, and of course they lie on a straight line. These are the counterfactual pairs. One of these, paracetamol, is counterfactual, and the other one, either paracetamol or placebo, is counterfactual, and the other one is real. This is the line of exact equality. These are the points here which, for every single patient. So that's what you would see, and of course what it shows is it's really a scale-dependent thing, but it's sort of stupid to say that some people responded and some didn't. Just measure them another time and they would change places. This is a generation of maximum numbers, and this shows you how silly everything is. Every single placebo duration here is reduced by about 1/4, and just because of the way we define 2 hours, it turns out that nobody here who had their headache reduced, although it was all reduced by 1/4, none of these are classified as a responder, but these 4 are. Why? Because they were the 4 that moved from being above 2 hours to being below 2 hours. They were the ones that were in this little bit of the diagram here. If you're in here, you're a responder. This is just gibberish. I promise you, most of any claims in medicine about the percentage of people that respond are based on gibberish like this. They're based on taking continuous measures and classifying people as responders and non-responders. So I've only gone halfway through, so now I'm going to erase one of the counterfactual pairs. This, for example, is again just 24 of these patients. This is the log scale because my effect is constant on the log scale. It's 1/4 of a duration reduction. The effect is constant. This is what I would see if I could see the placebo and the active. And here we have this sort of thing. A disgrace that anybody could interpret this as meaning that some people didn't respond and wouldn't respond. No statistician would do that. Unfortunately, yes. There is a paper in the American Statistician. Sander Greenland and I are both absolutely incensed by this. We've sent letters in promoting the D statistic, and in it claims that the D statistic, since it's a measure of overlap of two distributions, tells you the proportion of patients that respond. No, it doesn't. It doesn't do anything like that. You take one curve, you shift it to the right by a certain distance, Every single point on the first curve has been shifted. The two curves still overlap. The overlap does not give you the percentage of people who responded. That is just not thinking. And this is the simulation that accompanies the curves. And what that proves is either my mathematics is right or I made the same mistake in the simulation I made in the theory in the first place. And that wouldn't be the first place that it happened. But I'm fairly confident this is correct. Now, if I change the time at which there is a response, then in that case I can get very different numbers needed to treat. This is the number needed to treat corresponding for 2, and you get very different figures. But the basic point is any one of those is meaningless. They're all meaningless. They don't show you what percentage responded. To sum up, the results reported are perfectly consistent with paracetamol having the same effect on every single headache. This doesn't have to be the case, but we don't know it's not the case. And we don't know it's not the case because the Cochrane data, the data that were conducted, never involved measuring anybody for 2 headaches. Can you believe it? Nobody was treated for 2 headaches. Could have run a design in which we'd had them twice under placebo, twice under paracetamol for 4 headaches in total. We could then have done something like this, but they didn't. So the correspondence of combination dichotomies in responder analysis is the work of the devil, I should say. Never mind great potential to believe. It's absolute nonsense, and it happens all the time. Researchers are assuming that because some patients responded, and respond is one of these words that infects your brain. As soon as you label someone as a responder, you say, well, must have been caused. What they're forgetting is it takes hundreds, sometimes thousands of patients to tell whether the treatment works at all. How on earth can we tell by looking at one particular patient whether it worked for them or not? We would have to know what would have happened to them under other circumstances. So this is the pharmacogenomic revolution for you. We have clinical trials with a cleaner signal, apparently. Promised that 20 years ago. Must be just about to happen. Non-responders will be eliminated. We have treatment strategies which are theranostic. Therapeutics plus diagnostics. Actually, it's back to front. It should really be diapeutics because diagnostics comes first. Markets will have lower volume. It's a mystery why pharma marketing is so excited about this, but here's the rub. They're going to charge a higher price per patient day. That's why. Because the medicine will be for you. But the dirty secret about this all is that the biggest source of variation in the system is not patients, it's something quite else. What is that other thing? What is the other thing which is the biggest source of variation in the healthcare system? It's doctors. It's doctors. If you have a look at the way in which something like a woman presenting after breast cancer, a screening for breast cancer with a particular suspect lump or not, what happens to her next, that is completely different scenarios, nothing to do with the woman, everything to do with the doctor that she happens to see. The variation in the system is mainly not patients. So the implicit assumption is that most variability is genetic, and it's not obviously received in phenotypes you see already. There are lots and lots of genes which explain your height. But here's another dirty secret for you. If you want to tell how tall someone is, much better to get a ruler out. You could have a genetic readout, but actually be much better with a ruler. And so to the extent that height then predicts what happens next to them, and it does for certain things predict what would happen next, it'd be much better using the ruler than you would. This is what I call the phenotypic squeeze. All of that wonderful stuff in the genome is going to have to be stuff which is not already expressed in obvious phenotypes. We're going to be able to find its small number of genes responsible, low or no interactive effects. We'll know where to look. We're going to be able to do something about it. This is another dirty lie in many, many cases, and this has been the case in medicine. For ages, we could diagnose diabetes 2,000 years before we could treat it. And we simply don't know whether most variation in clinical trials is due to individual response, let alone genetic variability. So here is a sort of pretentious model I put up in which I imagine all the things that interact. For some reason, the spacing has gone to pot. But basically, these are the things we would like to know somehow, the things in the square boxes here. These these round things are what we actually observe, and we sort of try and make a judgment as to what goes on with the treatment inside this particular thing here. But, as I say, in many cases, it simply would be true that if we could somehow work out what, for a reasonably well-defined class of patients we currently see, what the best average policy would be, and get doctors to adhere to it, we would be reducing the variability in a system which would be beneficial much more. And in fact, that's exactly what Brent James, who's applying Deming methods to healthcare, is doing in Mountain Health. So just a reminder, sources of variation in clinical trials. Between treatments, that's why we do them. Between patients, we know different patients have different degrees of disease. Patient by treatment interaction, this is what everybody is focused on. They're obsessing by this. Every difference we see must be due to this. ACE inhibitor for you, beta blocker for you, diuretic for you. Must be your own personal drug with your genome on it saying what's best for you. And then within patients, what we forget is that actually you measure someone's blood pressure from day to day and it varies. If you run parallel group trials, then these three sources of error are confounded. You cannot separate them. You can try with repeated measures, but less than ideal. If you have a crossover, you can separate C and D from A and B, but you can't separate C from D. If you have N of 1 studies, so repeated crossover studies, essentially, where each patient receives each treatment in at least 2 periods, then you can begin to separate these two. And this is the reality again. My daughter has hay fever, as do I. My daughter is now in her 30s. She's a geneticist, and she says, "Daddy, you shouldn't talk about genetics. You don't know anything about it." I said, "That's fine. That's okay. I'm in good company." So anyway, so this is the medicine here. This is the reality of personalized medicine. It says here, it's important to know how much your child weighs to make sure you give them the correct amount of medicine. As a guide, a child of 9 years of age will weigh about 30 kilograms. If in doubt, weigh your child. This is really good advice here. And then do not give to children who weigh less than 30 kilograms. And then rather surprisingly, do not give to children under 2 years. It's a sort of strange match of these two particular things here. But anyway, that's what they say there. And then it says, adults and children over 12 years and over, 1 tablet once a day. And for children, 1 tablet once a day. Wow! This is fantastic personalization of medicine, isn't it? This is what really happens. And then finally, children of 2 to 11 years who weigh less than 30 kilograms, do not give this medicine. This is the reality of what happens out there. The pharmacocologist could tell you you could have been personalizing medicine years ago if you wanted to weigh people, if you wanted to measure concentration in the blood, but weighing is terribly, terribly complicated. You know, scales. And needles, won't sell a drug if you have to use needles, unless you work for the mafia. But basically, that's, and you know, I used to teach medical students, and I can tell you, I'm a bit nervous about suggesting you should weigh patients. Because what I know is that most patients would get a better dose, but some of them, believe me, would get an absolutely catastrophic dose. Because there is certainly a non-negligible fraction of medical students for whom decimal places will eternally remain a mystery. That is certainly true. So anyway, one has to watch out. So shock in Nature, and I'm fed up with this paper. Every time this gets discussed on Twitter, somebody cites this paper to me, and there's no way you can correct such a paper in Nature because it's an invited commentary, and they won't invite me to shoot it down. It needs to be shot down. It's nonsense. And what we have here, I've actually taken this diagram and changed it slightly, but essentially the same method. We have a number needed to treat for various treatments here. Again, the same error, NNT. And this gentleman seriously believes that these figures tell you these are the 10 best-selling drugs in the United States, tell you how many people respond to treatment. This is nonsense. They don't tell you that. A number needed to treat, a high number needed to treat, simply says the treatment is not very good on average. Whether that not very good on average is made up of very good for a few people and not at all for others, or not very good for everybody, you can't tell. You cannot tell from numbers needed to treat. You cannot tell these things. And if you have a look at one of these here, in fact, Advair discus asthma, he doesn't even get the condition right. It's not Advair discus asthma, which has a number needed to treat of 20. It's in chronic obstructive pulmonary disease, a different pulmonary condition altogether. And in the paper by Suissa that he cites as evidence for this, it points out to you, watch out, any number needed to treat is meaningless unless it comes with a timestamp. Because Suissa's paper started with the following: how come that Boehringer Ingelheim got a number needed to treat of 20 for 15 actually for one of their treatments, tiotropium, and Glaxo got one of 4. GlaxoSmithKline got one of 4. Well, it turned out they were measuring completely different things. But nobody had bothered to check that. It's just, number needed to treat. Wow, it actually means that Advair works for 1 in 4 people, where tiotropium only works for 1 in 15. But actually, if you take it and you use the same time involved, it's tiotropium 15, Advair 20. But that still doesn't say that some people are benefiting from one and not from the other. It doesn't tell you anything like that. It does not tell you that. So, it's ridiculous, naive, but depressingly common interpretation of NNTs. A number of times I see this all the time. People say, oh, but numbers needed to treat are so simple. And I say, yes, they're simple to interpret by simple-minded people, basically. The only simple interpretations of NNTs are wrong interpretations. They do not tell you the proportion of people that respond. They poorly understood how N of 1 trials should be used, so Schork is suggesting one should use them, but I don't think really understands the way they should be used in terms of mixed models, what the components of variation you have to identify and apply, and so forth. And certainly the fact that you shouldn't just rely on the observations from one patient when treating that patient. You should think empirical Bayes about the whole thing. And in fact, he's an expert on the topic. 20 years ago, he knew how to do components of variation. Then he was doing clever stuff in genetics, but for some reason this whole field just encourages people to abandon all critical facility, and they then say, well, there's a great big scope for personalized medicine, let's get that grant we're looking for. Good, he's calling for N of 1 trials, that's good, and actually if you do that and then properly analyze using mixed models, they could help us understand the scope for personalized medicine. So here's a thought experiment showing how. Imagine a crossover trial in hypertension. I'm going to take an ACE2 inhibitor, and I'm going to randomize patients to receive it or placebo in random order, and then because I'm a megalomaniac, I'm going to do it all over again. So again, one crossover and then do another one. So these are the possible sequences. In any pair of periods, they're going to get A and B once, but in a random order. So there are 4 possible orders, and then we repeat it again. So 2 possible orders, and then we repeat it again, so 4 altogether. So these are the possible sequences for any particular patient. And so here we have a plot. I've actually taken a very modest definition of response. I've said I'm not going to get away from the fact that the medics like dichotomies. I'm going to give 5 millimeters of mercury. They like 10 millimeters of mercury, but that's usually compared to baseline. And there's a regression to the mean effect, which will boost that as well because of the way patients are chosen for clinical trials. So I'm comparing the ACE inhibitor to placebo, and so I'm going to be more modest. I'm going to take 5 millimeters. Blue means they responded on both occasions. Here's one particular patient who had good response on both occasions. Red means they didn't respond on either occasion. Orange means they respond on one or another. These are the marginal distributions. I'm just showing off here. An old guy like me can occasionally use a smoother as well as a histogram. So here we have the 2 marginal distributions, and that's the scatter plot. So obviously, response in one crossover is predictive response in another. And in fact, that's correct. If I look at the correlation coefficient is 0.8, the conditional probability of observed response are the following. If you responded in the first crossover, your chance of responding in the second are 93%. That's pretty good. 0.93 chance of responding. But however, interesting lesson here, just because you didn't respond in the first crossover doesn't mean you don't have a chance of responding in the second. There, the probability is actually 0.41. Okay, but this is another diagram. This is a diagram with 0 correlation. So here, response in the first crossover is completely unpredictable response in the second. And if I look at this, yes, that's correct. Actually, it turns out that 80% of people respond, but it doesn't make any difference whether you're a responder or a non-responder on the first occasion. It's approximately 80% you respond on the second. So, supposing I had only one crossover. That's what I get to see. So which is true? So the situation is that most treatments are not studied on N-of-1 on crossover trials, let alone N-of-1 trials. You're lucky if you get this, but it still doesn't tell you about response. But in fact, most trials are parallel group trials, and they won't tell you about response. To study an interaction, you have to have replication at the level at which you claim the interaction takes place, more or less. So, here's my advice to you. Don't let the label responder infect your brain. A responder is a patient who was observed to get better by some arbitrary standard. In fact, every time you see the word response, you say, ah, yes, got better by some arbitrary standard. Remind yourself that that's what it means. Subsequence is not consequence. To establish who really responds and who does not, you'll need to work very hard. You need smart design and smart statistics. But get back to basic and understand components. It's components of variation we need to understand here. This is what the statistical greats taught us. Fisher in genetics and in experimental design, and Deming in quality assurance. What Deming said about quality for any particular system was the following: it's the duty of every manager to understand the variation in the system. And with healthcare, we are failing big time. We don't know the variation in the system. We're not doing things properly. We need to understand how much of the system anyway. I keep on saying this to people, you know, I work in Luxembourg, and it's a small country, and people in the ministry who pay for my salary and so forth, they're very keen about what I'm going to be doing for personalizing medicine for Luxembourg. And the sad fact is, a sort of nasty guy has to remind them of the following: most of anything that is of any good for Luxembourg will not be discovered in Luxembourg, and that includes personalizing medicine. On the other hand, don't look at it so negatively. Most of anything we discover in Luxembourg will be used for mankind as a whole, and there are far more of them than there are Luxembourgers. That's the way the economy of research works. If you want to do something personal for Luxembourg, then look at the healthcare delivery system, because these are the things that deliver from that change from country to country. There's a particular quite big country towards the north of the northern part of the Atlantic, which at the moment is agonizing about how to do something reasonable in delivering healthcare, has great technology, but very, very poor outcomes compared to most of the rest of the developed world, but I won't tell you who that is. If we have, so Deming says quality assurance and experimental design. But here I leave you with this final thought: the supply of truth always greatly exceeds its demand. Thank you. Yeah, Adrian.
So I did a lot of weight loss studies, well, not necessarily analysed, and although your primary analysis is always like mean weight change, you always have a PI who insists on some proportion of hitting 10% weight loss or 5%, and you get a big argument with clients to say that's rubbish, but in the end to say, you just go along with it because that's the secondary endpoint. Is that okay, or should we just keep on arguing against it?
I think you should. I think dichotomizing is an unforgivable sin. I just cannot understand why this is done. And it's really ironic, because what happens is the following: that the medic takes some continuous scale. I mean, you were talking about dichotomizing, were you there? Yes. Takes a continuous scale and dichotomizes it. Then what happens is the statistician says, I need to model this. And the first thing a medical statistician will usually reach for is logistic regression. And what does logistic regression try to do? It assumes you have a tolerance distribution behind the binary distribution. So essentially what you're doing is you're trying to reconstruct the continuous scale that was already there. And this is a really stupid thing to do. You should just measure the original data. Use the original data. There's a nice paper by Val Fedorov and Meninga, I think, in Pharmaceutical Statistics, showing that even if you're interested in the binary category, and personally I think you shouldn't be, but even if you are, you're often better modeling on the continuous scale and issuing a binary prediction at the end than classifying everybody as a responder, non-responder, and analyzing it in the first place.
Is it like the people who interpret the statistics, they think their proportions easier to interpret?
No, it's not easier. It's wrong. Yeah, but they're wrong. I mean, I had a PhD student I was jointly supervising. She was looking at diabetes as a precondition for stroke. And so she managed to find 8 papers where people had used particular classifications of people as being diabetic or not. And also she'd had a look at, they'd analyzed the outcome, and they'd taken something like the Bartel scale, which is categorical but with a large number of categories. And they classified into a good response and a poor response. Or it may well be that they'd used the NIHSS, there's some other scale which is even more finely devised, I think, and they then divided that. And amongst these 8 papers, she couldn't find a single repetition of the same combination of dichotomy of diabetes and dichotomy of stroke. And yet people were talking to each other as if they were talking about the same thing, right? So it's just completely meaningless. It's just because people somehow think that binary data are easier to analyze, and they aren't. Yeah. So, Peter, yeah.
2 comments. One, in defense of discretization or dichotomization, maybe at the level of covariates, I've often seen, especially in like bioinformatics, some folks like to discretize to avoid over-interpreting noise, like often when the covariates are like massively noisy, like we see it in genomic studies, it might make sense to just try to reduce it to some biologically meaningful protein is activated or not. Could there be a role there? And other question, beyond dichotomization, actually often isn't the problem even worse? It's not obvious what the relevant endpoint is, like that cut that goes beyond dichotomization, like should you take, I don't know, days of preterm delivery, mother's health, infant's health, when you talk about those issues. Like it's often not obvious what's the relevant endpoint, right?
I have difficulty. I'll give you an example. I went for a health checkup when I was at UCL because it was free, and one of the questions I got was how much exercise do you take every day? Do you take 2 times half an hour? And I said, no, I take 2 times 25 minutes. Because that was the walk essentially that was involved in it. And today, actually where I now work, I can say I take 2 times 25. I have a 2-kilometer walk to work, 2-kilometer walk back. I never miss it. Every day that I'm in the office, I do that. Rain, sun, I do that. 2 times 25 minutes. Doesn't count. Doesn't count. Why? Because in the epidemiological study, what they did was they simplified the questionnaire and they put down. But the really astonishing thing is that there are people who believe this is true. They actually think that you can classify mankind into those that work 30 minutes and above and below, and there's a fundamental difference between the two. It's ridiculous. And this sort of thing abounds everywhere. Everywhere you look at it, the scores that are created for categorizing, and it's just a loss of information. I just don't understand how we tolerate it.
Have you met Nicholas School?
No. Have you met him?
I'm so glad. One of the best things I did was he was seriously considered to be here as a speaker as well.
Well, would have been a chance to have a fight then in that case. No, as I say, if you look at the stuff he was, in that thing there, he was citing, he was doing components of variation stuff that was perfectly reasonable. I think that what happens here is that it's like what Henri Lippmann, who was a Luxembourger, by the way, so I need to quote him, he once said to Henri Poincaré, he said that the problem with the normal distribution is that the theoreticians imagine that the empiricists have proved it's an empirical fact, and the empirical physicists think that the theoreticians have proved it's inevitable. So that's basically what happens. And what happens here is that we have people who do test tube research at one end, and they can see, well, you know, they've got different regions. coding for different things. It must mean something. Oh, and we know it plausibly means something because all those clinical trial people tell us there's variation in response. And the clinical trial people say, well, there must be variation in response because all this genetics predicts there will be. But actually, nobody is studying the variation in the clinical trials properly. So when Schalk isn't working on this, he's just taking the NNTs from the EBM movement, and he imagines that they tell him this. Because also Cochrane, unfortunately, is full of people whose heart is in the right place. They're doing the hard work. They're looking for all the missing data. But their understanding of statistics is primitive. And so you get all of this stuff coming along that numbers need to treat somehow tell you what proportion of people respond, but they don't.
I have two other comments. On page 8 of your slide,
Yeah.
which is about this person Reeves lamenting that a lot of numbers are made up, and then you ended up saying like 88.2% of the data are false or something like that.
Yeah.
You didn't look at 88.2%.
It's just a joke. It's just a joke. I mean, the point was he made up that statistics as well. So he said you can make it. But he's not wrong. A lot of statistics are made up, or a lot of statistics are zombie statistics. But I mean, honestly, I ask you, is it acceptable that a major report by the FDA could quote something like this from 13 years earlier as justification for personalized medicine? Why can't they do better? Every time you follow this particular story, it ends in something like this.
So I just want to follow also Peter's mentioned also your comment about discretized continuous information. It's not just continuous, it's high dimensional information. And at the end, when physicians want to do something like personalized medicine, whatever, they want to make a finite number of decisions, right? So they can't really using the continuous information. And partially it's difficult for statisticians actually to convey the complex continuous information for this discrete space. There always needs some kind of cutoff value anywhere, and the cases around the boundary always be questionable because they are not that clearly different. And I have another question about N of 1, because recently in the work I get a lot of requests from medical doctors for N of 1. The N of 1 they are interested in is not like your case that you can actually cross over repeatedly. And they treat the patient. They say, if that one's successful, and then I'm done. This is for biological treatment. Maybe for proof concept, if biological process works, maybe. But it's not the right N of 1 that people are calling. And so I don't know how to communicate clearly. Because these cases, clearly, there's no N of 1. Once you treat, worked or not.
Yeah, I mean, you can use N of 1 for you can use N of 1 for chronic diseases. You can't use it for every disease. It has to be a disease where you can change, and you can't use it for therapeutic endpoints. You can use it for blood pressure, but you can't use it for eye damage, kidney damage, strokes, etc., like that. So you can use it in things like that. But to come back to the point you made about, I disagree completely with this simplifying of things. I really see no reason for this. You may at the end have to make a binary decision. That's correct. But there's no reason why that binary decision cannot be based upon continuous scores. And in fact, now our ability to black box this is much, much greater than it was in the past. There's less and less excuse for saying that in order for physicians to be able to operate something like this, we have to have binary categories. I just don't think that's true.
So the recommendation is give them kind of black box kind of way.
Well, yeah, I mean, yes, I used to struggle when I worked in the pharmaceutical industry, struggle to get physicians to accept analysis of covariance. We don't understand it. I would say, right, okay, so what's FEV1? Oh, it's forced expiratory volume under 1 second. I say, right, okay, so the forced expiratory volume under 1 second, how's it calculated? Oh, well, now let me see. I think it's the area under the spirometry curve. Oh, good, it's an area under the curve. I'd say, oh, yeah, that's good. Is it calculated using Simpson's method, or is it calculated using the trapezoidal rule? Or, what's the other thing, Romberg integration, or something more complicated? Or, how is it calculated? Oh, we don't know. The computer just tells us. I said, right, I'm the statistician. I've just told you to use analysis of covariance. Don't give me these stupid arguments. And you say, but you statisticians, you don't simplify things. I say, we don't simplify things. What about immunology? You simplify immunology, first of all, then I will consider simplifying statistics. We really have to get to a stage where we have a much more grown-up attitude about this. It's hopeless expecting that people can understand all of this. They can't, but they don't need to.
But you just said it's okay, like you acknowledge in the end you have to make a decision one way or the
Yes.
other. How about an indicator for being in one or the other region in the, of a decision boundary? That would then become a discrete score that you would be willing to accept?
Well, the point, again, the opportunity to be more grown up about this. So even 25 years ago, Jürgen Hilden was pointing out that one of the things that we do with clinical trials is badly is we force a decision, because we have lots of different things that we measure, and what we try and do is we try and put that into one particular decision. I used to think that way myself. I used to think it was important to find out how well the drugs did what we wanted them to do. I changed my mind to thinking we just need to know what they do, because the utilities of different patients could be different. So a particular patient might say, well, okay, here the situation is you've convinced me if I take this particular cholesterol-lowering drug every day, then my chance of stroke will be reduced by such and such. But personally, I find it such a pain in the neck that I'm not going to do it. And that's the decision that they want to make. So that's also something we have. That would be a way of personalizing, by the way. You know, personalize in terms of utilities rather than personalizing in terms of genetics.
Yeah, so I mean, it seems to me like knowledge is the act of discretization, necessarily. I mean, you talked about cancer not being a category, it being ridiculous to make cancer a category. And, right, we have melanoma, we have carcinoma, we have all these different cancers, and or HER2-positive breast cancer. What does it mean? It means HER2 expression is above some cut point, or we have some number of copies. And it seems like a large part of, I won't say personalized medicine, precision medicine, and maybe this falls into a different category, is just further breaking down those characterizations, right? You had Remicade up there for IBD, right? Remicade is useful maybe if we have overexpression of TNF-alpha, right? So it seems like a reasonable thing to look at. Now again, that's not an N of one, but it seems like there you take an outcome that you're interested in, I don't know, remission after 1 year, and then you actually just test.
Yeah, that's a very good point. If you were to go back to the 19th century, you would find that all sorts of things were classified as being consumption, which you wouldn't classify now. Now we would say tuberculosis, and that requires the bacterium, and that required Koch's insight, and all of that. But diphtheria is not consumption, and pneumonia is not consumption. Pneumonia comes in different varieties, and so on and so forth. And diabetes is no longer one disease; it's at least two, and it's more than that, and so forth. Yeah, all of medicine has involved that. But here the problem is that we're being sold some sort of incredible difference by an order of magnitude in all of this, which I really think, okay, maybe, but I worry when the people who use the arguments for justifying it produce statistics like this. Because that just shows that we don't know what we're talking about. And I would say that 90% of the people using numbers needed to treat, probably more, think they do mean that, but they don't.
Any other questions?
Maybe I would just reinforce the point that choosing a response is really startlingly shocking in some areas in medicine. I can think of one like in cancer control and prevention trials, where there were intervention, it might be delivered at a cluster level. But anyway, the final response is where the patient went for screening at 6 months after intervention. And they ask for millions of dollars for support, but they really take it 6 months. That's the time to decide whether the patient went for screening and whether then you conclude the intervention is effective or not. They wouldn't allow any other thing other than 6 months. I mean, with 5 months or 7 months, they totally discount that. And to me, I gave up convincing them that seems like maybe a better strategy can accommodate to find out whether treatment is effective and not a straight 6 months.
Yeah, I mean,
it should be personalized, like some patients may take a bit more time.
Yeah.
And
well, I mean,
the intervention is totally ineffective based on that. Seems like
Yes, it's. I mean, the combination of the screening plus also the combination of screening plus therapy is a whole other area which is very controversial. I mean, and I review quite a lot, often grant proposals in biomedicine, as I'm sure many of you do as well. And I had one recently where people were saying, well, you know, the situation with the colorectal cancer is that having treated the patients, there'll be a recurrence in this particular type in one patient in 10. And if we knew it was going to recur, we would treat them with chemotherapy. And, but currently we don't because it's really not worth it. And of course it does recur in some cases. So we've now got a screening method that we're going to use based on biomarkers, and it's going to improve the predictive accuracy of this. But nowhere in the grant proposal did it say how much would it have to improve for you to change the therapeutic strategy. So what I wanted to know is if you can now classify, if you can now split them into two groups, and in one group it's now 20% a high-risk group, and in the other group it's slightly less than that, less than the 10% it was before, you know, because the two have to add up, they have to marginalize the 10%. Would that make a difference? Because if at the end, having found this particular risk thing, it doesn't make any difference, in what sense is it important as a personalization? So the whole aspects of this which are not really thought through properly, in my opinion.
If I may add my 2 cents on this issue about dichotomization. I agree that if you have a continuous response, you should analyze it as continuous. But there are some situations where making it binary may be helpful. For example, the moment you make it binary, you turn it into a classification problem. You predict whether somebody is a responder and whether that prediction is right or wrong. And that often is a cost. There's a cost in that. And precision medicine is a business. Ultimately, there's a dollar cost. So if you analyze everything on a continuous scale, the first question is, what is the loss function you're using? Least squares? If you're using a Bayesian analysis, you may need a prior distribution on that. Maybe a population distribution may be hard to get. But if you dichotomize it, maybe the priors are easier to estimate from the population. So I think there's some advantages to dichotomization. It can allow the accountants, the drug companies to assess how much they will gain or the government has to pay. It's true that from the modeling point of view, if your raw data are continuous, then maybe you can get better estimates. But oftentimes, I have to ask, what is the loss function? I'm going to use these squares or absolute deviations. I mean, how do I fit that model if I have everything on a continuous scale?
Well, I mean, the diagram I showed you that the numbers needed to treat, for example, change depending upon where you fit the dichotomy. And then you have a look at a number of dichotomies. For example, there's a rather complicated dichotomy for response in blood pressure based upon a combination of systolic and diastolic blood pressures. But let's say one of the things that's used is a 10 millimeter mercury drop in diastolic blood pressure. So why 10? Well, it's because we have 10 fingers. Oh, and wait a minute. No, it's because actually at the time of the revolution, the French decided they were going to create a new measure of distance, which was based upon what they thought was the distance from the equator to the pole or something like that, right? It's because traditionally we measured the blood pressure in terms of mercury because that was a common thing to do. So we end up with 10 millimeters of mercury as being the way to measure this. But if you were to use 8 millimeters or 12 millimeters, you get a different answer. And so I worry about this. Can it really be true what you say here? Can it really be true that somehow in some sort of dollars and cents that this makes sense? I think it means people are being misclassified. But in any case, as I pointed out there in that particular example, in the headache case, it's simply meaningless. It just is meaningless.
Thank you.